Good evening, everybody. Welcome to this evening's little webinar session on flexor tendons. We've got people still logging in, but we've got enough to get started. It's a huge topic, as you can imagine, so trying to compress flexor tendon review plus rehabilitation into an hour is a challenge, so we'll have to move quickly through a lot of things. So what I'll say in that regard is that it is an advanced clinical session, so there'll be some introductory anatomy, things like that. That's going to be fairly quick, but this webinar will be posted later on YouTube, so you can go back and revise it in more detail at another time. So we'll fly through the anatomy and the basic physiology, and then try and get onto our flexor tendon repair strategy. And importantly, we have a guest panelist tonight, hand therapist, to talk to us about some of the principles of hand therapy. We're not going to, again, in an hour, we can't talk about detailed protocols and individual protocols, but we're going to talk about principles of hand therapy and rehabilitation. So tonight we've got just over half of our people registered already with us, but we've got a fair number of people today from all over Australia, New Zealand, and we even have some medical and allied health people from Brazil who are logging in today. So if they're here with us already, welcome to Brazil. A little bit of housekeeping matter. If you have a question along the way, put it into the Q&A rather than into the chat, and we'll do a Q&A at the end and try and get to all of those questions. All the questions that you've put in beforehand, I've tried to incorporate into the slides already where they're relevant. So we'll get on with things, and I'm kicking off, and then we'll hand over towards the end to talk about rehabilitation. Okay, and we're kicking off with a question today. We're going to start, we've got questions along the way, so we'll kick off with a question about the most important factor in successful flexor tendon repair and rehabilitation. So you put your thoughts in. I'm just interested in what everyone's thoughts might be, whether it's a rehabilitation protocol, number of suture strands, patient understanding, or timing of the repair within 3 days. That's good. We've got 80% of people saying it's patient understanding, and a smattering of others in the other areas. So yeah, about 76, 80% saying patient factors, and a little bit with those other ones. So yeah, that's interesting. It's probably a little bit of a setup because maybe it's my personal preference. And I'll get on to a bit more of a discussion about that at the moment. To me, it's patient factors, and I'll talk to you in a moment about why. We're also going to talk about, principle. The whole thing today, as I said, is a principle-based discussion. We're going to start with the anatomy because we can't do anything without that. We'll talk about some key considerations in flexor tendons, how they heal and why we do our repairs and therapy the way we do. Rehab with Colette later, and a little bit more discussion about the difficulties and the absence of a one-size-fits-all. We'll start, well, the history is going to come a bit later. We're going to start mostly with anatomy, then biology and biomechanics, and then we'll move on through our surgical approaches, rehabilitation a bit later on. So this little phrase, maybe no one's ever heard it before, maybe I just made it up, but I think of lots of hand surgery in a biopsychosocial way. So, it might be a novel concept, new phrase, it may not. Biopsychosocial hand surgery. So what is that? Well, it is what I just spoke about. It's all of those patient factors. Now, we probably in the old days called it compliance or diligence with therapy, but it is more than that. It's everything to do with the patient's life. It is how compliant they are, but how engaged they are, what other external pressures they've got in their life, their own psychological response to the injury, their development of rapport and their communication with the treating team. So all of those things come into play. And just for your benefit, unprompted, I'll give you this little pearl of wisdom from me, but I genuinely believe more surgical procedures fail because of lack of communication than any complex technical or medical oversight. And this old classic in surgery, that surgery is 90% decision and 10% incision. So 90% of it is the decisions you're making and the way you're managing the case. 10% only is the technical elements. Digital function's very complicated, and as we've learnt more about digital function and about the tendon nutrition and healing along the way, we've had a great development in the way we reconstruct and rehabilitate tendons, and the results have improved. So it's a very complex anatomical structure, and the healing is very complicated, and that has meant, as we have discovered more about it, our results have gotten better. So we can't go anywhere without the anatomy, and as I said, we're not going to dwell on this for too long because we'd be here all night, but our flexors are divided into 3 layers. This superficial group here with our pronator, I'll switch over here, our pronator, our FCR, our palmaris and FCU in the superficial layer. 1 layer down in this intermediate group, our FDS, and as we saw last week, you can see this proximal leash of FDS here and a potential compression point for median nerve. We've got FDS coming down in that intermediate group. And our deep group, which lies beneath our neurovascular structures under here, our profundus tendons and our FPL. As we go to the carpal tunnel, our tendons, all our digital tendons pass through the tunnel along with the FPL in a slightly separate sheath. And these flexor tendons have a fairly characteristic position with the profundus tendons still deep. The superficial tendons up more superficial to the retinaculum, and just in this configuration with the 2-5 tendons deeper to the 3-4 tendons. So launching another little question here. In what percentage of people is the FDS to the little finger absent? Got a few options there, 5, 15, 30, 75. Okay, good response there, 70, 80% voted, that's pretty good. We'll end that there. It was good, quick voting, everyone there. So 15% is the winner, with 30% following afterwards. And in fact, 15% is correct. On my presentation here, I've got a little range, but 16 to 23, 15% is often quoted as the number. And usually, or not usually, about 26% of the time there's asymmetry. So usually if it's if it's on one side, it'll be on the other as well. So an interesting thing about little finger FDS. Tendon blood supply through the vincula. Now they arise from these transverse digital arteries, and there's short and long vincula. So here we have the vinculum brevis for profundus and vinculum brevis for superficialis, and then the long vincula here. This diagram here shows nicely our tendons and this chiasm here, Camper's chiasm, as the profundus tendon passes through the decussation of the superficialis tendon. We can see our vincula as well. Much nicer than that, though, is actual intraoperative picture. And we can see our short and our long vincula to our superficialis going deep as it decussates, and the profundus tendon here going up towards distal phalanx. This slide is simply a reminder that that the tendons in the palm are not isolated, that the lumbricals arise from the profundus tendons within the palm. The pulleys are extremely important to prevent bowstringing in the digit. They're condensations of the sheath consisting of the cruciform and annular pulleys, and there's 5 of them. Well, originally there was described 4 annular pulleys, but there was later by Kleinert and Brody a 5th pulley distally described. And we won't forget that the final pulley in the palm is the transverse carpal ligament. So sitting down in the palm, the transverse carpal ligament confines the long flexors there as the final pulley, preventing bowstringing. Another little quiz point here before we talk about our zones. What anatomical point defines the transition between flexor zone 1 and flexor zone 2? Anatomical point at the transition. Just wait for our last few votes here. 60% voted, a few don't know. That's looking I like an 80% response rate. That's not bad. So FDS insertion is the winner there, with 76% of the votes, with FDP following on behind. So the winner being the FDS insertion is the anatomical point which defines the transition between zone 1 and 2. And that is in fact correct. So zone 1 being distal to that insertion, and zone 2 being from that insertion all the way proximally to the A1 pulley. And then 3 is carpal tunnel to A1 pulley here, 4 and 5 in the wrist. This perhaps demonstrates it in an even nicer fashion. Our insertion point of FDS here, A1 pulley there, the transverse carpal ligament defining zone 4 and zone 5 proximal to that. This diagram very quickly just shows us the tendon sheaths without the highlighting of, without a gross highlighting of those pulleys. But the sheaths themselves are these enclosed synovial fluid-filled sacs that bathe the tendons in fluid, which allows some nutrition, which we'll talk about in a moment. And in the 3 central digits, they tend to end in the distal palm. With the little finger and the thumb, they can continue to the volar wrist and sometimes communicate, hence our horseshoe abscesses from time to time. So tendon biology. The tendons are mostly collagen. They receive their nutrition by diffusion, which I said, so they're bathed in that synovial fluid, but also they receive it by perfusion. So perfusion from the arterial supply and the vincula, and diffusion from the synovial fluid. This is important to our healing later on. The collagen, which mostly makes up the tendon, is metabolically active, so it requires nutrition. But there are some avascular portions and watershed areas. And these watershed areas early on created some of the confusion which led to the disbelief in intrinsic healing. So some of that intersynovial tendon has these watershed areas. The examination and histology in those areas early on made people think that they were avascular. There was a relative lack of cells and they had no intrinsic ability to heal. So that led us up the garden path for a while. In terms of the biomechanics, well, they're very strong. I mean, the flexor tendons are fairly dumb, but they're strong, not like the extensor hood. They're very powerful, but they pull in that unidirectional manner. So they need to be strong. If we're repairing them, we need to have sufficient number of strands in our suture. We need to place them in the right position, and then we can, if we like, add in epitendinous sutures to increase our repair and try and minimize any gap. If we want that intrinsic healing to occur, then the tendon needs to be communicating. We mentioned that before about perfusion and diffusion. So the perfusion is through our vincula at the junction, up proximally in the forearm, at the insertion, and then through the vincula. Diffusion is through fluid, synovial fluid, and this is obviously pumped around while we're using our hands during motion. Tendon healing can occur by intrinsic or extrinsic means. So although it can heal intrinsically, if it's left alone, it will heal extrinsically, which we actually don't want. We'll talk about that in a moment. So we have this supportive healing from the synovial fluid, diffusion. We have more intrinsic cell activity and fewer adhesions if we're moving the tendon. But we get healing from the outside by ingrowth of fibroblasts and inflammatory cells if the tendon is not moving enough. So that's what's responsible for developing adhesions. So there will be an inflammatory response, chemical mediators, etc., causing healing. And there's some theories that maybe reducing those mediators can reduce the adhesions. But most of all, if you're moving, it's not going to get stuck. Now, this is all developed fairly quickly in very recent times. As I said, there was confusion early on, thinking that adhesion was from the sheath. Healing was from the sheath. It was extrinsic, and they had the tendons had no ability to intrinsically heal. But some work in the 70s, and this is a real game changer, was able to confirm this capacity for tendons to heal intrinsically and with synovial fluid nutrition. So even in tissue culture, they were able to heal without any synovial seeding. So this knowledge of intrinsic tendon healing really changed the way tendon repair was able to be performed, and most importantly, changed the ability to rehabilitate actively and get those tendons moving. The timing is fairly similar to most wound healing. So we have an early inflammatory phase with the injury, then blood clot and early inflammatory infiltrate. They get a little bit of dye back at the tendon ends, and the only strength you have there is, well, suture if you put it in, a little bit of fibrin and clot. The proliferative phase is 3 to 6 weeks, and that's when you're really starting to look at formation of a tendon callus and real fibroblast proliferation, which is really starting to pick up and peak at 2 to 3 weeks. Again, very similar to other normal wound healing. And these fibroblasts invade and formalize the callus, again, similar to other wounds and similar to bone. Remodeling occurs for a long time after that. So for 6 or 9 months, the tendon will then be organising itself and remodeling. And this creates a much better gliding surface and increased strength over time. If there is extrinsic healing, it's via this ingrowth of fibroblasts and inflammatory cells and causes adhesion. Okay, we mentioned that before. And this little diagram just shows sort of nicely diagrammatically, if you're getting this cellular ingrowth from the sheath in to assist with tendon healing, it's going to be stuck. And these are our adhesions forming from extrinsic healing, which we're trying to avoid. So in tendon repair, something like this, a classic sort of minimal wound, but with this diagnostic posture of extension, loss of the flexor there. This was something unheard of in the early parts of last century, or even towards late parts of last century. This was the no man's land here and was to be avoided. So early on, completely avoided until really Kleiner in the late 60s, when he started to gather the courage to do the repairs here and do them primarily. Before that, they were all done with delayed two-stage tendon grafting. These days, in terms of timing of repair, we want to get it done as quickly as we can. If we can't do it immediately, we need to do it as soon as possible. If our facility can do it, our hospital, and if the talent is available. So if we don't have someone, these tendon repairs, particularly around zone 2, need to be done by the most qualified person available. That gives us the best quality and strongest repair and the most amount of information moving into our rehabilitation. So repair it immediately, but if a suitably qualified person is not there, repair it as soon as they're available, is what we're saying. Of course, that goes in conjunction with wound cleaning, debridement, and antibiotics, etc. If you leave it too long, everything gets harder. You develop contractures, the sheath becomes stenotic, you can't pass your tendon back up there anymore. It's a real problem, particularly if the tendon's retracted and the musculotendinous unit has shortened. So getting these done quickly promotes a better result. In terms of anaesthetic, really the type of anaesthetic is secondary to the quality of the repair. There's also those psychosocial elements to consider. If someone's extremely anxious, doing them under a local anaesthetic only or wide awake is probably not very humane. These repairs are possible under any type of anaesthetic. You can do them under local wide awake, you can do them under general anaesthetic, you can do them under spinal blocks and axillary blocks. But what you need to be asking is, if I'm going to do it in a particular way, am I going to be able to execute a very high quality repair? And if you're confident, then you select the anaesthetic that firstly is available and secondly is suitable to the patient. The surgical approaches, this diagram really sums them up nicely in terms of extension. We just want to make sure that we're not crossing directly over flexural lines and going to cause further contracture. We don't want to cut any of the neurovascular structures if they're intact. And on here, it's a nice example in this flap here, where we're seeing a nice mid-axial extension here with a broad-based flap, but a much more angular back cut here. My preference would always to be going for the right angle and make this flap as broad as possible. The more that narrow these skin flaps get, particularly in trauma, the more likely you'll get some necrosis of the tip here. Similar here with this classic Brunner type incision, we may want to extend up more at a right angle and come around to make this flap broader, just to protect those tips. Any wound breakdown or further infection is going to make our rehab harder, so the better quality the skin and closure, the better our result. This is an example of it here, extending this incision in this mid-axial direction first before coming across, and just makes this flap a lot more robust. Interestingly, and just as a little point, if you do make a sharp angle across here, what will often happen is this will break down and start to discharge, and people will say, oh, it's bad luck, the wound got infected. Well, it's not really bad luck. Often it's just an avascular narrow tip to the flap. So why do tendon repairs fail? This is probably more important than many things. Well, some of it can be the injury, a really severe frayed injury, poor quality tendon, a great deal of destruction in the local soft tissue. The others can be surgeon error or technical error. That's poor suturing, wrong suture technique, that sort of thing. There's patient errors, of course. That's what we would ordinarily call non-compliance. And there's possibly therapy errors, although that's very unlikely. The hand therapy is so highly developed and the protocols are so rigorous that would be quite unlikely. So failure is more likely to be one of these first three, I would think. There could be other reasons, but one of these first three is the most likely. So repair techniques. I've got a little sub-question there. Do they influence the outcome? Firstly, do we need to repair partial lacerations? Well, there is a debate in this, like many of the things we'll get into in a moment, but lacerations up to 50% can be treated without formal repair. If you think about it, that makes sense. We've got 50% of quite a large tendon. There's a lot of intrinsic strength there. But if the laceration is beveled, you occasionally need to trim down the tendon to make sure it's smooth so there's no trapping or triggering. Occasionally, putting extra suture material into a partial laceration can just provide a nidus for inflammatory response or infection and can actually lessen our result. So being conservative about suturing when there's only a partial injury is important. Suture techniques, there's plenty of them. They proliferated early on with people wanting to get forward their own technique to repair tendons, but a few became very popular along the way. And my next question addresses exactly that, just to get a survey from everybody regarding what sort of sutures techniques are most popular out there at the moment. And we know what it used to be in the past. It'd be nice to see what people are doing these days. That's a good response rate there. 82%. Well, that's interesting and probably not what I expected. I would have to admit I expected the four-strand Kessler to still be the most widespread, but I'm encouraged to see that four-strand Adelaide is very popular. Six-strand, my surgical mentor still uses it, but I don't have this graph on the presentation today, but we do see that as our tendon, as our number of strands goes up from 2 to 4, that strength goes up. But as we get to 6, it drops off the other side. And again, that might be similar to our discussion with partial repairs in that it's creating more of a nidus for problems. So four-strand, it does tend to be the best balance of all things. I expected the old modified Kessler to still be the most popular globally it probably still is. This is a 2-strand modified Kessler, but the 4-strand version is very popular. But this is the Adelaide repair, sometimes called the Sandow repair, but this is the Adelaide repair. It's this 4-strand cross-grasping technique. It's very strong. It takes a little getting used to, but really nice to repair. If you get these bites here, a good centimetre either side, it's extremely strong. And then you add to that a cross-stitch or over and over epitendinous, and you've got a very nice and neat repair. That's what I use for my tendon repairs, and it's good to see that the popularity of Adelaide is going up. Here's just a bigger version of it if anyone wants to come back to watch the video later and study it. But this is what the Adelaide repair looks like. And it's just got these really nice bites where you're able to grasp onto the suture and the suture's holding itself in the tendon. It's very strong. Just going with a few details in the zone. So zone 1's very difficult. Full function of the DIP is difficult when you get the zone 1 injuries up the end of the finger. And it's distal to that FDS, as we said. Often they're going to be avulsions, this jersey finger situation. And when we see that avulsion type injury, ring finger is the most common. Someone asked in the questions before this webinar about these avulsions and the Leddy-Packer classification, and really it's just saying in type 1 the stump's back here in the palm. In type 2 you still have the vincula intact, so it's holding here, and in type 3 you're talking about a fracture, so it's stuck at the end of A4. They're very difficult to repair because, well, you don't have a lot here to suture onto. In terms of technique up there in zone 1, that's a whole nother discussion. But really, because you don't have another suture to another end of tendon, you're looking at using different types of bone anchors or screws or transosseous sutures to buttons to try and hold that tendon on. So in doing that, you've got to keep it immobilized for a long time while the bone heals or the tendon heals onto the bone, and that results in that loss of range of motion in the long term, and the results being not quite as satisfying. In zone 2, the surgical approach we've already discussed with this mid-lateral or Brunner type incision, getting really close access. And then the big decision is about what to do with our pulleys. We'll discuss pulleys briefly in a moment, but really trying to preserve A1 and 4 as much as possible. If we need to get our tendon from inside the palm, we have to do that. And hopefully the sheath hasn't become stenotic and we can pass that tendon back up to where we need to do our repair. And then doing our repair and dealing with our tendons as we've decided before discharging them from the theatre in our dorsal splint. To repair the tendon, it's the old registrar's curse, fishing around, trying to retrieve the tendon from the distal wound. But these, as I developed, I'm sure most of the surgeons and senior registrars out there would find that they're very quick to bail out to a more proximal incision to find the tendon and pass it back up. It can save an enormous amount of time, and the morbidity of the incision proximally is not great. The pulley management is controversial. There's a bit of a split in the evidence base. There's advocates for 3 real groups that people divulge into: preserving the pulleys at all costs. There's people in that camp. There's venting the pulleys and leaving them open as long as you've got an intact A2. And there's venting and repairing pulleys. These are the groups that develop, and they've all got their reasoning behind it. I think I just have one last question here before we move on to rehabilitation. And I will just fire up this last question here to talk about people's experience with poles. I'm very interested to see what the result might be here, because I know what the result is whenever this question is asked at hand surgery meetings. So what is your preference? Presuming you've got A2, what is your preference with the remainder of the pulleys and your tendon repair? Yeah, that's getting a 64%. Any of the hand therapists, you can have a guess. Have a guess what you'd like to do. All right, that's interesting. Okay, we'll end the poll there and just share those results. So the results are that 70% said vent the pulleys and leave them open. 20% said leave the pulleys intact, and 10% said vent the pulleys and reconstruct them. So vent and reconstruct in the minority there. So that is interesting. Often we get more of a 30-30-30 split with these 3 options. And it's interesting that pulley reconstruction seems to have faded away a little there. If I'm to give my personal opinion, I vent them and leave them open because leaving them intact, you can have to settle for a second-rate repair. And if you vent them, you'll get a better quality repair. So I put all my eggs into getting the best repair I can. And then I found that if I reconstruct them, it creates a point for triggering. The repair is bulky and it locks and triggers over this pulley repair you've done. So I tend to vent them and leave them alone. So with that in mind, that's a whirlwind run through some of the anatomy and the important points. The tendon healing pathway all links into what we're about to talk about now, which is rehabilitation. So what we're doing in rehabilitation is based solidly in what sort of repair we've got and why, and the timeframes for tendon healing. So I'll hand over to Colette Zemlich, who is a senior hand therapist from Brisbane, who I work with all the time. And Colette's going to run through some of the most important principles and features of tendon rehabilitation. So Colette, are you there?
So thanks very much for inviting me and having me along. This evening we're just going to talk a little bit about rehabilitation of flexor tendon repairs. Thanks for that really useful background and refresher. I know all the therapists have been texting me saying that that's actually been really helpful to us. And Cam was sharing with me earlier that a lot of the surgeons are interested in hearing what I've got to say, whereas I think the therapists might just go to sleep. So hopefully this is useful and interesting. So I want to talk a little bit beyond the protocol. I won't go into great details on protocols this evening. Really want to look a little bit more at the clinical reasoning and some of the decisions that we make as we're going ahead and rehabilitating flexor tendons. So initially there's 3 key players in any flexor rehabilitation process. The surgeon, of course, and Cam's talked about that. We certainly need to take into consideration the surgeon's preference and the factors pertaining to the surgical process. We've got the patient and what they bring to the process. And then, of course, the therapist. We need to gather as much information as we can, build an ongoing relationship with our patient, and create a plan for the process that will unfold. We need to engage the patient in this process. We also need to monitor this process ongoing and make changes as appropriate to the moment we're in and what we're seeing. It can be said that success is a third responsibility, but it can also be depending on the interrelationships and communication between these 3 throughout the process. And interestingly, Cam, I think you earlier slightly absolved us of responsibility there, but I would probably put us back in that game.
Thought I'd be nice.
Very kind. In the case of a work cover claim, there might also be some additional stakeholders which come into play with a greater or lesser extent, but that's probably a little bit beyond the scope of this particular conversation this evening. So there's some important information that we're looking for. When we first get a referral for a flexor tendon patient, it's very important to us that we get a useful referral that includes lots of information, and often it's very helpful for us to have the copy of the operation report, and I know it's always the first thing that I look for because that gives us a lot of this information and probably saves our surgeons some time in passing that on. So things like the degree of laceration is very important for us to understand. Is it 100%, 50%? What's the quality of the tendons? And was it an end-to-end repair, and how is that going to, impact on our rehab and wound healing process? The structures that are injured or repaired is important, as it will influence adhesions or the need to protect other repairs, possibly nerve or artery repairs that were also done. The zone of injury and other surrounding structures have an impact on the ability for the tendon to safely regain motion. I'm not going to go into great details about those zones. Thanks, Cam, for talking through that earlier, but things like zone 1, is there a bony element to this injury? Zone 2, are there pulleys implicated? Zone 3, other lumbricals intact or affected? Zone 4, the carpal tunnel. 5, the involvement of the musculotendinous unit, which may vary our healing timeframes and our glide, and may impact what we decide to do in terms of our therapy protocol, if you want to use that term. What's the strength of the repair is important. So we want to know a little bit about the suture technique, the number of strands across there, and does the surgeon feel that it's going to tolerate an early active motion program or not. The tightness of the repair is helpful to understand. Oh, sorry, I've been fiddling that. And how tight it is will influence the safe positioning in the splint and the total excursion that will be possible. Significant retraction of the tendon or time frame from the injury to repair or any segmental loss may also be influencing factors in that and help us with decision making around the position we place our patient in their dorsal blocking splint. Then, of course, there's the time frame from repair, which is critical because in the first 48 hours, there's increasing edema, increasing friction developing, and we know from early research that glide is very dependent on suture strength. And then initially, and then as time passes, the tendon strength as it starts to pick up. The status of the wound and other local trauma is important to us. And the quality of the tendon ends will also influence their holding capacity for the repair that was done. Finally, the involvement of pulleys, and Cam's just talked about that, and whether they've been preserved or repaired, as the pulley enhances the function of the tendon in flexing the finger, but it also increases the constraint or resistance on that tendon in its ability to glide. If the repair is just distal to the pulley, it can also increase the risk of gapping. All right. So protocols, they're familiar to us all. We've probably all read, at least heard about Duran, which was a passive only, or Kleinert, who introduced the concept of active extension with passive flexion. The Belfast, which introduced the idea of early active motion, and then the Indiana protocol, which included the concept of tenodesis, to glide the tendons with finger flexion during wrist extension and finger extension during wrist flexion. And I can see you're all probably trying to do that behind your computer screens there. I was sort of planning on demonstrating that. More recent developments of that have included the Manchester, which utilises similar concepts in a short splint design, so still utilising that wrist tenodesis action in rehabilitating that flexor glide. So they're all ways and means of creating or allowing enough tendon excursion within its bed to prevent extrinsic adhesions while preventing full excursion, which could lead to rupture. They're all meant to be a guideline. They're not intended to be a recipe. They're certainly not a one-size-fits-all, but then there's the question of when do we change the rules, how do we change them, and what influences our clinical decision-making. We do need to be familiar with all of these different protocols, because that helps establish the foundation of our reasoning skills. But because you can read through those in any textbook, we won't go into those in detail. It's important to remember that our initial goal, though, does not equal our final goal. The initial goal is to create enough glide of the tendon to prevent adhesion while preventing gapping or rupture. And our final goal is full contraction or elongation of the musculotendinous unit in order to achieve both full flexion and full extension. Immobilisation and passive range of motion protocols have been shown in the research to have an increased risk in reduced motion due to the development of early extrinsic adhesion and scar, whereas active range of motion protocols have the benefit of early glide, and early in the history of tendon repairs, a high risk of rupture, but with the improvements in tendon repair techniques, this is vastly improved. So that brings us to talking about glide. And when I went to Google to find an image for this slide, it gave me all sorts of things: running shoes, golf clubs, hang gliders, motorbikes. Couldn't quite get my head around that one. Someone's going to have to actually explain how motorbikes glide to me, but clearly it's there. I was looking for something more like an ice skater or a kayak, smoothly gliding effortlessly across the water. No squeaky grittiness, no clicks, no clunks, crunches, just smooth, effortless glide. Well, there was also the good analogy of dental floss, but whilst that's a perfect example of a smooth gliding tendon, it's not nearly as sexy as a kayak on a smooth lake, or as memorable. So when you think of the glide or excursion of flexor tendons relative to their surrounding bed of tissue, I want you to have in mind the goal of smooth glide, minimal friction, no catching, minimal effort. I, along with many other hand therapists, often describe it to my patients in therapy as the effort required to hold a butterfly still, but without crushing its wings. So that leads to the discussion on friction, or the resistance to glide. And there are two major sources of resistance, and we each have a role to play in overcoming it. There's the internal resistance, which, as Cam has outlined, is very much a surgeon's job to control. As much of this as possible with careful management of suture technique, placement to minimise bulk, consideration of pulleys and prevention of gapping, and so on. And then you've got the external resistance, which is something largely managed by the therapist and the patient throughout the rehab program. So I always like to commence all exercises with passive flexion to minimise the joint stiffness, and that's very important in reducing the friction on the tendon as it's pulling against that, and the load, in fact. Careful edema control. I can't emphasise elevation enough in the first post-op week. I think managing and preventing bulky dressings, which will only add to resistance. And then quality scar management is also important, with optimal wound care to prevent delays in healing. Early massage and moisturising are also helpful. And it may include also supporting any pulley repairs. Finally, managing load and effort through a well-educated patient with the use of analogies is critical. Essentially, this leads us to the concept used widely in the literature now of the work of flexion, being the energy or pull needed to overcome resistance in order to flex the finger. Too much resistance too early will result in rupture, and it's our job as therapists to minimise the amount of resistance the patient encounters as they attempt to do so. We need to help them with working in their safe zone. So this is a very fine balance between the force needed to initiate movement or gliding on this side over here, and too much force resulting in gapping or rupture. It's also important to recognise that this safe zone increases slowly with time. So as we progress through our rehabilitation program, we can be a little bit thoughtful of that. There's some other things as therapists that we consider or aim to overcome. Patient factors such as their age, their health, healing potential, presence of comorbidities such as diabetes, etc., that may impact on wound healing, patient motivation or socioeconomic situation, their mastery and compliance issues, which Cam's talked about, which all have an impact. Whether the injury involved was crush injury or clean laceration, whether it involved a tearing component, such as you might see with a grinder injury, which also has an impact on wound healing, edema and scar formation, and therefore friction and resistance to glide. So early scar management and optimal management and debriding of wounds to reduce external resistance is going to be important. Whether the injury occurred in flexion is also important, as then we may have a tendon repair that is in fact distal to the wound site, influencing the point at which during flexor glide the most resistance may be encountered, and whether or not there's an FDS and FDP injury at the same level will influence the bulk of the repair, particularly of issue in zone 2. As healing and rehabilitation progress, the presence or absence of adhesions will have an impact and require modifications, which we'll go on to talk about in a little bit more detail. Work of flexion and the implications for rehab. The work of flexion is greater at the end of range due to the increase in joint angles distally. And as can be seen from this little graph here, it's interesting to note just how much the resistance to movement increases as the flexion increases. So throughout the first sort of half to or quarter to half of the range of movement, we've got sort of slight to moderate resistance, and then the resistance increases significantly through that last portion of the full fist. This is also impacted by the external and internal factors that we've already talked about. So therefore, it's important that we wait to work on end range flexion as the weeks go by. So generally, we'll work through a 6-week progression, commencing with a third of a fist in week 1, a half a fist in week 2, 3/4 of a fist in week 3, and the tips to palm in week 4, with progressive tucking towards the distal palmar crease over weeks 5 and 6. And by then, patients understand quite well the concept of taking movement to the point of tension with the least amount of effort and resistance. And a concept that's been talked about a lot in the hand therapy community is, using strategies to help the patient replicate that amount of movement that you're describing to them. And one technique is to actually use the fingers placed in the palm and have them working down towards a new finger each week. So here, working in the first week towards the index finger, and the second week you'd work towards the middle finger, and so on until you're down into the palm. And the interesting thing and the useful thing about that is it actually also improves the FDP glide, because you'll see it backs up the MCP joint a little bit and encourages the FDP to pull through a little bit more than in, say, this picture here, where they might be making what they attempt is a half fist, but in fact what they're getting is very prominent FDS glide. So just a really nice technique for helping to get some nice differential glide of that FDP in the early weeks there as well. So then on to the question of how do we manage adhesions? Well, first of all, I think it's very important that we first and foremost prevent them. So through good education and getting started early, within the first couple of days, I like to make my splint within the first 24 to 48 hours and establish a relationship with the patient. often, you know, start with them with the gentle concepts of movement and exercise, and then review them around the day 3 to 4 mark and really get them going with their exercises from there on. Their active exercises from there on, sorry, my phone's text messaging me. Very important that we don't tear any adhesions as we're going. We need to be extremely gentle and just attempt gentle movement as we're progressing through the range. Where it's appropriate, you might want to actually create some blocking and isolate glide to an area of adhesion if you're noticing adhesions occurring. And here's just an example that I've used with the use of little Bunnell style blocks to get independent FDP glide. You can also use it down on the FDS. I start it over on the unaffected fingers digits first, and then move across to the affected digits. And you'll note that little blocking device is moved very quickly away. It's not actually held with any force against the finger. It's just a cue, a sensory cue, if anything, to help the patient with isolating the glide to either the FDP or the FDS if that's what you're trying to work on. Using some early prehension patterns in combination with synergistic wrist movements. So from 3 weeks, we like to start them dropping out of their dorsal blocking splint with a little bit of wrist flexion and some more finger extension as they do that, and then a little bit of gentle active finger flexion as they're coming back into their splint. I generally don't allow them to remove their splints at home. We'll practice it with and without the splint in therapy, but at home I get them to do that in their splint. We might also consider using an element of passive motion in combination with some synergistic wrist and MCP or PIP joint positioning and PIP joint positioning. And I'd just caution you with this one. It's one that you'd want to be using with an experienced therapist. It's certainly not an exercise that you'd be giving your patients as a take home, but we've successfully used this in order to achieve some nice joint stretches when you've got risk to joint stiffness and you're holding and positioning the MCP joint and the PIP joint in some good flexion whilst actually extending the DIP joint, and then conversely holding the DIP joint and the MCP joint in some flexion whilst encouraging a little bit of PIP joint extension very gently and passively. And you can kind of combine that as predominantly an active with a gentle assist rather than a true passive in order for that to be truly safe. We might also consider using block extension exercises, and we might start that one actually quite early, using a paddle pop stick down behind the digit in their splint, blocking the MCP into some greater flexion, encouraging good PIP joint and DIP joint extension. Or you might consider some extension splinting at the appropriate time, and this is just an example of one that was a little bit of a tight tendon. We were popping a little sponge in back behind it to block the MCP into some more flexion, and she was practicing her PIP and DIP joint extension in that. The nice thing about this is you get to use the little bit of lumbrical protection provided by the lumbrical, which is rising from the FDP tendon, which encourages some nice slackness in the actual FDP whilst you're achieving some good PIP and DIP joint extension. And then passive extension splinting, is there a place for that? Some people do consider putting some splints on at the appropriate time, somewhere around about the 6 week mark, maybe while the patient is in their splint. This is an example of just a very gentle approach using some tubie grip on the patient to position their finger gently into extension whilst blocking the MCPs down. It's just a little bit of a more prolonged rest that they could actually take in that position. I generally start with something like that for a couple of hours just in the daytime if they need a little bit of more PIP, DIP joint stretch in order to encourage that. And then we've got a couple of other ideas here, some encouraging them to do some sustained cylinder grips on progressively smaller and smaller pieces of dowel. You might start on a thick pen and then work down to a regular sized pen before working towards full grip in order to increase their flexion. And these are obviously things that we would use in the later stages after we've ceased working on functional activity outside of splinting. Paper towel crumpling, I'll talk about that a little bit more in a moment. Transferring of small objects from the tips to the palm, and putty squeezing or scraping are some nice ways of managing adhesions or breaking down adhesions in the later stages of therapy. But on all counts, with any of these techniques, it's most important that you avoid any sort of provocation of inflammation. So when it comes to activity out of the splint, as we look at gradual and careful weaning of the splint from 6 to 8 weeks, and there is real benefit of practicing tasks before releasing them to do normal daily functional activities. And this is just an example of your paper scrunching activity that I will often get people doing as one of their very early therapeutic activities before they start doing real life function. And it's really about them being able to retrain some of the proprioceptive aspects of hand movement, which is often, I find, quite impaired when they first start coming out of their splint. So practicing, I think, makes perfect in any situation. And this is one which I like to do. Any other small in-hand manipulation tabletop activities that are very, very light are nice precursors to suggesting to your patient that they take off their splint and start doing functional activities around the home, because it's very, very easy to very quickly overload that tendon. Then you follow that with commencing very light function and strengthening from 8 weeks, and we use theraputties and things to do that, as well as other activities of daily living, with return to normal activity not occurring until about that 12-week mark, which you'll all probably be aware of. So, in summary, remember the impact of internal and external resistance factors on the work of flexion and smooth, effortless tendon glide, and keep them front of mind in the assessment and treatment, reassessment, modification of treatment programs as you're going. And finally, if your approach isn't working, change it. Identify problem tissues and target those specifically. Measure what you're trying to change, because I think that always helps to see progress, and patients really appreciate that. And at every session, assess both the patient competence with their rehab protocol. So starting from your very first session after you've taught them their exercises, watch and listen to how they do it themselves, and polish up their own technique before they go back home and do those exercises again themselves. It's important that we also assess tendon function and make sure we palpate, observe, measure what their passive range of motion versus their active range of motion is. Obviously, the passive is later in the rehab process. And practice your exercises in therapy as you want them to do them, and observe them again, over and over again. Can't emphasize how important that is. In one of the early questions, just before Cam comes back on, somebody was asking about the success of Zone 2 and what kind of success can you expect from a Zone 2 flexor tendon repair. And this is the example of the case that I had at the opening slide of my talk. And you can see that at 14.5 weeks, it is possible to get full active extension. Now, she didn't have composite extension with the wrist moving into extension at that point, but she did have full digital extension in wrist neutral. And progressively over the next couple of weeks, she improved on that. And she really did have full active flexion. When you consider that this was the starting point for a delayed repair, that's an excellent outcome. So Cam, was there anything further there that you wanted to add, or?
No, I think that was a good summary. We would just encourage, if there's any questions there, to put them in the Q&A, because we'll be coming to that in just a minute. If there's anything else you want to ask Colette, we will be hanging around for a while for the Q&A. So if that's all you had to say, we'll just polish off the formal parts and get to our questions.
Sure.
Thank you very much, Colette. It's a rare thing to have this sort of discussion as a joint exercise, so it's good to run over the rehabilitation basics as well. As I said, it's very quick run through because trying to condense all this is difficult, but hopefully we've shown very, very quickly the anatomy, why it's important, all of those important biological factors, why we do our repairs, and then that nice little summary. just to point out a couple of very interesting points you made there, and one of the main ones was if your approach isn't working, then change it. I can't stress that enough. If you're sitting and you've explained this protocol to the patient in absolute perfect scientific detail, right down to the letter, and you look at them and they're staring at you blankly, you've got to do something different. So you've got to play to the patient's strengths. The other thing you mentioned was about the free gliding and the passive warm-ups, and that's something Don Lalonde's been right onto recently, is not doing active. But I think what he really means is like not starting any treatment session with actives. You've got to start with some passives. You get some good glide, you free up any early adhesions, and then you can do your active. So that warm-up ranging is important. So other issues which we can talk about another time. We didn't even get a chance to talk about delayed flexor tendon injuries. There were some questions in the registrations about PIP joint deformities, Boutonniere, FFDs, and how to manage them. I think I'm going to do a whole, if you tell me in your feedback if you want a whole session on PIP joint injury and deformity, because I think that's a whole session in itself. We didn't talk about tenolysis or pediatrics or two-stage repairs or what the future holds. So there's so much more we can talk about. So let us know, topics for future discussion. Now, in the Q&A, we've got a few questions that have rolled in here. So we'll go to our first one. And we've been asked, we're talking about Jinbo Tang. Jinbo Tang suggests you just need to keep 1.5 to 2 centimeters of sheath anywhere, and you don't need to worry about A2 or 4 specifically. I would absolutely agree with that. In fact, Jinbo Tang also was a big proponent of the passive warm-up and then active exercises, just incidentally. But if you look, leaving any sheath is better than no sheath. If you can leave a pulley, that's better than just sheath. I think it's a ladder. So if you don't have any ability to leave your pulleys and you've just got sheath, then that's great. And I think what they're saying is that you'll still get a reasonable result. But if you can preserve your A2, and often you can, a lot of these sharp injuries are distal because they occur in flexion, and then with the extension you find that the injury is much more distal. So if you can preserve 2, you're doing well. If you can preserve some sheath, because 2's gone, then that's the best you can do. But I would agree. If you got 2 centimeters of sheath, you're going to be okay. Hang on, we've answered that. So next one, in a tendon graft, proximal tendon graft in zone 3, how can we avoid impingement of the pulvitaft weave at A1? Well, the simplest answer to that, I would think, is to vent A1. So if you've got a repair and you've got a pulvitaft in zone 3 here, and again, it may have occurred in flexion, and then as they extend, it abuts the A1. If you've got your A2 and the rest of your sheath intact, as Jinbo Tang said, you can just vent it. So if you're impacting and impinging on your A1, just get rid of it and allow that tendon to glide properly.
And at that level, can I just ask a question? I might sound a little bit dumb. Would you expect the lumbrical to be impaired?
Well, it depends on the nature of the injury. So, it could be, if it's distal enough, you'll still have sufficient lumbrical attached.
So if it's
if it's distal enough, you'll still have your lumbrical there.
Yeah.
If it's proximal back at lumbrical, and again, it's a nature injury. So if it's sharp, it's going to be different to if it's explosive or destructive.
Yes.
So big crush injuries are going to destroy your lumbricals more than a sharp penetrating wound in that level. So as long as you haven't denervated it, you repair the whole thing. what's the next one? So someone's asked they'd like an outline of early active hand therapy for their exams. So but rather than going over it, is there a resource available for standard, is there an online resource for standard early active protocols that we can direct people to?
Is it standardized?
Oh, well, a list of all the standards. I mean, there are various books for various organisations, and they all have their own bent on early active programs.
That's the thing. So, I mean, you've got your Belfast, which is your early active. There should be one. The Echo Hand Therapy Manual, which the protocol manual is due out shortly, but I'm not sure whether that will be out in time for the exams. And that certainly would have what we're currently using as our early active protocol.
Is that published only, or is that online?
It's not currently available online. I think eventually it will be. So, and it's still pre-publication at this stage.
Yeah.
So in terms of what we're using in Brisbane, that is probably the most.
Yeah. If that's a surgical registrar asking that, I don't think you need to be too detailed about it. What you said, Colette, about when you're starting your passives and then your actives and going to quarter, half and full fist and the timing of those.
That is it, really.
That's a sketch of, dorsal blocking, splint, edema control, passive warm-up, active exercises and working through that range. That's sort of it, isn't it, in a sketch?
Yes, absolutely.
And I would think for a surgical registrar and an exam, if you can talk that sort of language, you're going to be fine.
So I did outline it, but I guess I didn't put it all on one slide. So those photographs that I showed where the patient is moving down through the quarter, half and three-quarter fist, that is your 6-week in the dorsal blocking splint protocol. The positioning of the dorsal blocking splint might also be important, but there again, it's very difficult to be prescriptive as to what that should be for an early active motion. I mean, I think optimally we're looking for around maybe 10 degrees of wrist extension and sort of 45 degrees of MCP joint flexion with the IP joints in full extension as being the optimal dorsal blocking position. Now that's not necessarily their post-op cast, but that's what we're aiming for as our goal in an early active motion program as their splint position, but that will be influenced by all of those other gliding factors that I was talking about. So we adjust that and pop them back into wrist neutral if they're a little bit tight, or if that's where we get the least amount of resistance to glide. So we're always looking for the position to achieve the least amount of resistance to glide, and that is the position we're aiming to position them in for their splint. There'll be some influence of the zone of injury that might also influence that.
So it's quite dynamic. We've had a couple of people send through some suggestions. There's a link there and there's a reminder of the PRS article by Don Lalonde. And again, we're talking about Jinbo Tang. He's got an article from 96, I think, which outlines their protocol. So you can go and search for a million, everyone will have their own different protocols. But for the registrars, I think the important thing is knowing that knowing the basics, why we're doing what we're doing in terms of that tendon healing pathway and the biology, and then some basics about that we've highlighted here. You can read a few, but you'll get a feel from reading a few that there's a common themes, and that you just need to be adaptable as well. And last question we've got here is how to assess the difference between tendon gapping or adhesion. I think gapping, like minimal gapping, is probably, to me, not a huge issue if it's a few millimeters. And in actual fact, there's some suggestion that a minimal amount of gapping can, reduce some of the tension and everything, and actually the outcomes are fine. Rupture, so when you're talking about gapping, that's sometimes soft language for rupture with pseudo tendon interposition. So, gapping is, a little bit But rupture, you end up with the whole thing coming apart. And the way you tell the difference there is by doing an ultrasound scan. Really, you just want to go and have a look inside, or if you're genuinely convinced, then you just go and open it up and have a look. In terms of adhesion, it depends on whether it's extrinsic adhesion to the sheath or whether it's adhesion to the other tendon. So you can often see that if things will be moving nicely, but they're not going to be moving independently. So I would rephrase that to, how do you tell the difference between a tendon rupture or adhesion? Minimal gapping is going to recover okay. Your thoughts on that, Colette?
Oh, look, I think one of the really important things is consistency in therapists, because if it's the same therapist assessing it over time, you'll have a little bit of a sense, because tendon gapping, you might, particularly if it's a sudden gapping, I guess you'll see a significant difference between one session and another. And that's a bit of a cause for concern.
The other thing's going to be timing. So if you're in the first few weeks, it's different to if you're at week 10. So you're not going to expect gapping at week 10 or adhesions really to develop at week 10. They're going to develop, both of those problems will develop later, will develop earlier. If you have a problem, that late, well, that would be really unlucky. But let's say week 6, if you have a problem then, you've probably ruptured more than anything else. So
your adhesions don't usually come into play until sort of the 2-week mark. Unless they're pre-existing or they haven't been dealt with intraoperatively, if I'm allowed to be so bold.
Yeah, it's going to be in that maximal proliferation phase, week 2, week 3. Things are going to get stuck then. And as I say, if there's the same team reviewing the patient, they're looking at it, things are getting just a bit sticky, it's not a sudden problem, then you're probably okay to work through it with some of those techniques you were describing. But if everyone's, if there's a very sudden change, one day it's moving, next day not moving, it's adhesions kind of develop more insidiously compared to ruptures. But from the medical point of view, we just have a very high index of suspicion. You can't let yourself be convinced that it's not a rupture. But there's a lot that that get through the gate. You think it's still moving okay. It's not too bad, but there's been a rupture and it's separated by a full centimetre and a half, and this pseudo tendon forms in the middle, and so they're still moving but not completely. So I would call that a rupture, not a gapping, but it's like a masked. It's a disguised rupture with the pseudo tendon. You eventually go in there and there's no tendon. We've got one more question come through. We might as well ask if there's still, a good number of people hanging around. So what stitch do you use for FDP Zone 2? I use Ethibond. I was just talking to Colette about this afternoon. I started on using nylon for everything because it's so forgiving. When I was learning, using nylon just allowed me that little bit of slide and give to get things together if I wasn't quite right. And Ethibond doesn't do that. You have to get your tension right, or if you're slightly gapped with your repair, you can't pull it in with an Ethibond. So when I was learning, I couldn't do that well. So, but I've now graduated to Ethibond and I can control it. The other thing I added was I do the back wall of my epitendinous first. So I pin the tendon, and I do the back wall to set my tension. And so then the tendon's sitting in a nice position, and then I do my Ethibond to set the tendon right, and then my front wall to tidy everything up and make that smooth gliding tendon. So Ethibond, but there's a bit of a learning curve with Ethibond. So just be a bit careful early on. And I would definitely recommend doing your epitendinous back wall first. And you'll just, it's like your microsurgery. It's all in your setup. If you set yourself up well, you've got your tendon opposed, it's sitting there, there's no tension, back wall's done, then you're going to be in a much better position. In any reconstructive surgery, but particularly micro and tendon repairs. If it doesn't feel right, then change something and get yourself set up, because if it's awkward at the start, it's only going to get worse. So any other questions at all? It looks like everybody seems to be going quiet, so it's dinner time to quit. So please leave some feedback, and I'm happy to do more of them. Tell me what you'd like to hear about, and we'll get something underway again in the near future. I hope that's been useful for everybody. Thank you, Colette, for coming along tonight.
Thanks for having me, Cam. It was a bit of a new experience for me. Yeah,
well, it's the new way of doing things. So thanks, everybody. Please leave some feedback for us so we know how to get better next time. And we'll see you then. Have a good night.